Welcome and good morning. On behalf of the Partnership to Fight Chronic Disease and our partner organizations, we're really happy you can spend an hour with us today to discuss the tremendous impact and cost burden that chronic disease has on our healthcare system, and more importantly, America's patients. I'm Jay Keese of Capital Advocates. I lead federal affairs efforts for the partnership, and I'll be your moderator for today's discussion. We have a great panel of expert policymakers and thought leaders today, and I'll introduce them in just a minute. And this has been a major focus for the Partnership to Fight Chronic Disease for years. So first, a little bit about who we are. PFCD is an international patient advocacy organization. Our partners include a wide range of stakeholders: patient advocacy groups, providers, provider organizations, employers, unions, health systems, pharmaceutical companies, academics, and all of those who've come together to raise awareness of the leading cause of death and disability and the number one driver in healthcare spending today, which is chronic disease. About 84% of healthcare spending goes towards the treatments of these chronic diseases, and we're talking about diabetes, hypertension, heart disease, stroke, cancer. More than half of Americans suffer from one or more of these diseases, and the number goes well beyond 90% of spend in the Medicare population. And as we've seen in the COVID pandemic, Black and brown Americans are likely to suffer disproportionately from chronic illnesses. We have a great panel today to talk about some of these issues. So here's a little bit about our speakers. First, Dr. Ken Thorpe is our chair, and he is also the chairman of the Robert Woodruff Department of Health Policy and Management in the Rollins School of Public Health at Emory University. Ken was Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services in the Clinton administration. And in this capacity, he coordinated all the financial estimates of President Clinton's healthcare reform proposals for the White House during the healthcare reform task force. He also directed the administration's efforts in dealing with Congress on important healthcare reform proposals and has acted as an advisor to presidents and members of Congress ever since. We're fortunate to have with us today Dr. Donna Christensen, the Honorable Dr. Donna Christensen, who is a retired member of the U.S. House of Representatives, where she served 9 terms as the delegate from the Virgin Islands. She is the first female physician to serve in Congress in the entire history of that body. She's a graduate of the George Washington University School of Medicine, and she completed her residency in family medicine at Howard University. She had a private family practice until her election to Congress in 1996, and she also served as the health commissioner for the Virgin Islands. In Congress, she served on the Energy and Commerce Health Subcommittee, and she chaired the Congressional Black Caucus Health Brain Trust for 16 years. Dr. Michael Mandel from the Progressive Policy Institute is chief economist and vice president. He's the senior fellow at the Mack Institute for Innovation and Management at Wharton School at the University of Pennsylvania. He was the chief economist at Business Week prior to its purchase by Bloomberg. Mandel supervises PPI's research on the economics of innovation and the growth in both the public and private sectors. Some current key issues include pharmaceutical pricing and innovation in the era of COVID, the economic benefits of digital manufacturing, job creation by new technologies such as e-commerce and 5G, and the regulation of cross-border data flows. Mandel has written 4 books, including The High Risk Society, and his economics textbook, Economics: The Basics, is in its 4th edition. Michael Ward is Vice President of Public Policy and Government Relations for the Alliance for Aging Research. Michael leads the organization's regulatory and legislative efforts to support research and to ensure access to therapeutics and high quality care. His work at the Alliance has contributed to innovation in value assessment, measurement of consumer preferences on vaccination, and on the analysis of impacts of proposed legislation on the therapeutic pipeline. Before joining the Alliance, Michael held key policy roles at Premier and the American Hospital Association and Avalier. So today, we're really going to try to focus on what's best for patients living with these chronic diseases. And as the Senate prepares to revisit reconciliation and tackle some prescription drug reforms, we've long asked policymakers to shift their focus on what's best for the patients. It's obvious that the cost of prescription drugs is a problem. But when we look at the real drivers of these costs, it's increasingly borne by individuals living with chronic conditions who are now exposed to these greater out-of-pocket costs due to high deductibles and other drivers in patient care. COVID really pointed out the need to be careful about any reforms that could curb incentives on new drug innovation and new vaccine innovation. And PFCDs spent a ton of time looking at the data behind the health impacts of the cost for these people living with chronic diseases. And with that, I'd like to turn it over to Dr. Ken Thorpe, who'll go over some of that data and lay the land a little bit for us today. Ken?
Well, great, thanks, Jay. Good morning, everybody. Thanks for joining us. We want to talk about what we think are some real opportunities to make progress on prescription drug prices. And as Jay has been pointing out, our focus is on what can we do to make those medications more affordable to patients. And the most direct way to do it is to really build on proposals that are sitting there in the Senate that started with capping out-of-pocket costs for insulin at $35 per prescription. We think that's a great idea. Definitely a move in the right direction. What we're proposing to do is to build on that, to expand those out-of-pocket caps or elimination to other chronic diseases, including a broader set of diabetic medications, including insulin, but also looking at capping out-of-pocket costs for medications used to treat congestive heart failure, past stroke, hypertension, COPD, and other really key chronic healthcare conditions. To me, the real policy focus on prescription drug prices is this out-of-pocket component. That's something I think we could get done. That would make the biggest difference for patients in terms of their health outcomes compared to anything I've seen proposed previously in earlier versions of the prescription drug price legislation. This is not a new concept. As I know, most of you are aware that in the Medicare Advantage program, they have a value-based insurance design component now available to all 50 states that allows health plans to reduce or eliminate cost sharing for a broad range of chronic healthcare conditions. And what we have found with that experience is that medication adherence has gone up, total spending has not. I'm going to give you some other data that shows even more favorable numbers. So half of the Medicare population already is benefiting from reduced or no cost sharing from a whole range of chronic healthcare conditions. What we're proposing to do is to include that as a Part D benefit for everybody, all the fee-for-service patients as well as Medicare Advantage patients. So again, not a new concept to Medicare. We're just building on what's already in the Medicare Advantage program that CMS has put forth some years ago. We also have a lot of data out there looking at the impact of eliminating or reducing cost sharing for drugs. We have a couple of NBER, National Bureau of Economic Research studies that have shown that if you eliminate or reduce cost sharing, not only does adherence go up, but particularly among patients that have multiple chronic conditions, let's say 4 or 5 conditions, which is not unusual in Medicare. 60% of the Medicare population has 2 or more chronic healthcare conditions. But if you look at that population and reduce or eliminate cost sharing, yes, of course, spending on drugs goes up, which is the primary way to manage these chronic conditions in addition to good primary care. But what we found is total Medicare spending goes down. So every dollar reduction for the really sick population in out-of-pocket expenditures leads to about a $1.80 reduction in total Medicare spending. There's another recent study out of Louisiana that the private sector did this in their Blue Cross plans. Again, eliminating cost sharing on chronic disease medications. The same results. They saw an increase in adherence, better health outcomes, and a reduction in total expenditures. So not only does this make sense from a patient's perspective in terms of better outcomes, better adherence, and adherence is really a major part of keeping chronically ill patients healthy, but it also has potentially a positive financial impact, as the data that I've just gone through suggest. So there are other parts of the discussion on drugs that focus on bringing in artificial European regulated prices to cut total spending. That really is, as we've looked at this proposal versus that proposal, the proposal I just outlined in terms of capping or eliminating out-of-pocket costs has far bigger benefits for patients than those existing proposals that would cap out-of-pocket costs at $2,000 and bring in European price setting to arbitrarily set price levels. This is a much better direction to go. I would hope that we focus on the real important part of this prescription drug discussion, which is the patient, which is improving their health outcomes, making it easier for them to fill and refill their medications. And this is a very simple way to do this. So we're proposing to build on the insulin cap component. Let's expand it to additional chronic diseases, which are the bulk of the spending in the Medicare program. And that's going to be the most direct way to really beneficially help patients stay healthy. So, Jay?
Well, thanks, Ken. And that's a great segue to our next speaker. Dr. Christensen has spent her entire career, both as a family medicine doctor and as a patient advocate in Congress, in really trying to help patients improve their care. And so we'd love to hear your thoughts on this issue, Dr. Christensen.
Well, thank you, and good morning, everyone. And the proposal sounds great, and I'm really looking forward to this discussion. You know, I sit on the board of Consumers for Quality Care, and we have been looking at out-of-pocket costs and the increasing burden that it places on patients, but we've been looking at the private sector. We haven't looked at Medicare. And I would guarantee you that most Americans think that people who have Medicare have everything covered, but it's not the case. And this discussion is going to elaborate some on that. I personally had a experience last week in a discussion with some women who were talking about access to care and the cost of care. And I was quite surprised when a retiree who had just applied for Medicare Part B found that her and her husband's costs, both of them had just retired, were over $500 out of pocket for their premiums alone, not to mention co-pays or deductibles. And so they were both paying together over $1,000 a month. They were able to, over a 6-month period, to find a way to reduce that through working with CMS. But that was an unexpected cost. It was a high cost. And I dare say that many people could not weather that kind of a cost imposed upon them. So we in Consumers Quality Care have looked at copay caps because our surveys show that the premiums, the copays, and the deductibles are some of the costs that patients are not able to handle. It is causing people to delay care. So the proposal, as Ken talked about, would get people into care earlier, avoid catastrophic care, and actually, as the studies he mentioned have shown, will eventually reduce the cost of healthcare, not only to the patient, but to the federal government as well. So I'm looking forward to this discussion. It's timely. I think there's no question that people are burdened by medical debt. I think Kaiser estimated that maybe 100 million people are in some kind of medical debt. And when we look at bankruptcies, about 62% of bankruptcies are for medical debt. So we really, this is something that we need to tackle.
Well, thank you, Dr. Christensen. And Dr. Mandel, this has been a particular focus of yours on the overall economy and on issues like inflation and so give us your perspective on the impact of these out-of-pocket costs and some ideas about how we can move forward in this debate.
Thanks very much. Yeah, so inflation, a few words on that. We all know that inflation is running out of control in the entire economy in a terrible way, and part of that is reality, and part of that is that we have to be able to sort of control the costs that we can control. And copays for chronic disease drugs is one of the few things that we can control at this point. I mean, Congress has been doing the right thing by focusing on copays for insulin, capping copays, and the idea of sort of broadening those caps to sort of chronic disease drugs will actually have a much bigger effect, not just on what people are paying, but on their perception of inflation as well. Because what's happening, a few years ago, I sort of wrote about the prescription escalator, and the prescription escalator is the fact that the number of prescriptions that people are having to fill each year rises as they age because they have more chronic conditions. So they have this perception that, and reality is that they're paying more each year. And the easiest way to control that is by capping copays. Now, the original idea of copays was a good one. That the idea was that the way we would control drug costs was by making sure that consumers had some skin in the game. But it really hasn't worked out the way people expected. We're balancing the budget on the backs of the sickest patients. And if we want to control inflation, if we want to sort of show people that we are actually doing something about it, capping copays for chronic disease drugs may be the simplest and easiest way of doing that. Especially, we're talking now, just be clear, we're talking about Part D, okay, which is what the government has direct control over.
So thanks, Dr. Mandel. Michael Ward, you've spent, again, an entire career on doing research and now focused directly like a laser beam on people in the Medicare program. So let's hear your perspectives on this issue.
All right, thanks, Jay, and good morning, everyone. So, prescription drug affordability impacts nearly every person as their care needs increase as they age. However, though a large percentage of beneficiaries report being happy with their Part D coverage, especially beneficiaries that may not yet have significant or chronic care needs, there is a large number of beneficiaries that are facing tremendous financial liabilities in order to access needed medicines. These costs are especially acute when deductibles and benefits reset at the beginning of each year, though it continues as patients are responsible for up to 25% of their drug costs under original Medicare during the coverage phase of their drug benefit. The impact of these costs is not trivial. A growing body of evidence shows increases in patient out-of-pocket costs. Leads to lower drug adherence, higher mortality, and increased overall healthcare costs. Last year, the National Board of Economic Research, NBER, which Kim mentioned earlier, found that patient cost sharing introduces large and deadly distortions into the cost-benefit calculus. This finding remained true regardless of a beneficiary's socioeconomic status. So even beneficiaries that were in a better position financially still avoided filling their scripts or otherwise did not adhere to their prescribed medication regimen due to cost. The NBER analysis of Medicare data found that out-of-pocket cost growth of just $10.40 per prescription led to a 23% drop in total drug consumption and a 33% increase in monthly mortality. So as cost sharing increases, this stark rise in mortality isn't due just to cutting edge and life-extending treatments for conditions such as cancer, but for patients that are cutting back on basic life-saving medications for chronic disease, such as hypertensives, anticoagulants, and statins. Unfortunately, the number of Medicare beneficiaries facing high out-of-pocket costs for prescription drugs is growing. The Kaiser Family Foundation found that the number of non-low-income subsidy beneficiaries reaching the catastrophic phase of the Part D benefit has increased since 2010. In 2019, More than 1.5 million beneficiaries had out-of-pocket expenses exceeding the catastrophic threshold of $5,100 a year. However, patient liability before the catastrophic phase continues to increase each year. So in 2022, patients have to pay over $7,000 in out-of-pocket costs before their coinsurance drops to 5% in that catastrophic phase, though there is still no limit on a Medicare beneficiary's maximum financial liability for prescription drugs. The Alliance for Aging Research started Project Loop, which is Project Lowering Out of Pocket, to serve as a way for organizations to get involved and to advocate for meaningful policy change, including an annual cap on a patient's out-of-pocket liability for prescription drugs. Medicare is the only major insurance program that lacks such a cap, and the ability for patients to pay their costs in zero interest installments over the course of a year, known as smoothing. More recently, we've been working to explore how to simplify the Part D benefit design through promising ideas such as a broad application of a flat copayment, such as CMS has been demoing in the insulin space. However, expanding it across all conditions, similar to the concept that PFCD has discussed today. No one should have to choose between their health and other basic life expenses when they are standing at the pharmacy counter. I look forward to today's discussion about how Congress and the administration can advance meaningful change for patients. Thanks, Jay.
Thank you, Michael. And great introduction to the issue here. And again, as I pointed out before, it's timely because the proposal before the Senate right now is just one of, many proposals that are out there. The proposal that was in the House last year, there's a bipartisan proposal. Senator Warnock and Senators Collins and Shaheen have a proposal out there to cap insulin costs and patient costs. And yet the key issue that keeps these things from moving forward is usually the cost. It's either it doesn't save enough or it spends too much in one area or another. But what's the reality on the economics here? If we're going to add other categories of drugs to the current proposal to cap out-of-pocket costs for insulin, is that just not going to sort of raise the price of this thing? So some thoughts from our economists, maybe I'd like to hear from Ken and Dr. Mandel on just what the impact of adding these new classes would be.
Well, CBO has made some progress in this area. They understand that there are interactions between the use of medications and spending elsewhere in the healthcare system on hospital care, clinic visits, ER visits, hospital and ambulance rides, and so on. They do score an offset for an average patient of around 25%. However, I think if you look at the recent studies out there, they are increasingly showing, particularly for the sickest of the sick. And let me give you a picture again of a typical, Medicare patient. It's a hypertensive diabetic with bad cholesterol, COPD, maybe asthma, maybe has had a previous stroke and is depressed. That's our patient. They're on multiple medications, and adhering to those medications, we've seen in the data reduces overall spending. So I cited the statistic that for patients with 4 or 5 or more chronic conditions, that a $1 reduction in out-of-pocket spending reduces total Medicare spending by $1.80. We've seen it in the private sector as well. So I don't think that the focus should be on, sort of a marginal increase in scoring on this. I really don't believe the numbers if they're showing out to be big positive numbers at all. I mean, the data in terms of the studies belie that. They're pointing in the opposite direction. I think our focus should be on that patient I just described and how we can make it easier for them to fill and refill their prescriptions. As Michael Ward mentioned, that MBER study found that by increasing the coinsurance rate or copays that patients pay for prescription drugs for Medicare patients results not only in a reduction in adherence, but an increase in mortality. Mm-hmm. So we have those links between out-of-pocket costs, total spending, mortality rates. I think those completely override any sort of marginal scoring that CBO may do that says this may cost some money. I think the reality is it doesn't. The data don't show that. And I think if you're thinking about sort of managing chronic disease, and you talk to Dr. Christensen and others, I mean, the way you manage chronic disease is to make sure that they are adhering to their medications and following their medication routine, and they're getting good, timely primary care. I mean, that's sort of the regimen to make these patients healthier. And why in the world would we want to have even a $2,000 cap on what these very, very sick patients pay out of pocket? It makes no sense. This benefit design that we're talking about in Medicare really comes from the 1960s in terms of private health insurance plans, where chronic disease was not common. I mean, it was really designed as a way to deal with moral hazard for basically non-chronically ill patients, to get them think on the margin of whether or not they should use the healthcare system or not. We're in a whole different world now. In the Medicare population, over 95% of the spending is linked to these chronically ill patients. You do not manage healthcare spending in chronic disease by having high co-pays, deductibles, high co-insurance rates. It makes absolutely no clinical sense in terms of managing these patients, and it doesn't make any economic sense as well. And I think, again, the data are very compelling on this point. Not only from an economic standpoint, but from a clinical standpoint. Just talking to physicians and say, why in the world are we charging patients all of this money? In Medicare, a 25% co-insurance rate linked to the list drug price to fill a medication, it doesn't make any sense. So I'm hoping that in terms of the legislation that we can get passed this year, that we really do something right for these patients, and eliminating or capping co-pays for a wide range of chronic disease medications.
So let me add a few words to what Ken said. Okay, I mean, I agree with pretty much everything he says. I will say that at PPI, we do think that spending is important and keeping an eye on it is important, but we've created a situation here where we've set up a situation which is feeding inflation, okay, which is feeding the perception of every year people's co-pays go up with list prices, and the number of drugs as they have more chronic conditions, okay, that they have co-pays for go up, and each of them adds up over time, and the amount of uncertainty. I mean, Mike Ward sort of mentioned, having the front loading of payments, makes people having to sort of deal with all this uncertainty and how much they have to pay out. And so we have an obligation, especially in this high inflation environment, to look a little bit beyond the spending and sort of think about what we can do to sort of reduce the impact of inflation on people, and being able to sort of flatten out the co-pays for chronic disease drugs for Part D recipients is one of the most straightforward ways we can do that. And it has the benefit, as Ken says, of improving people's health as well. Yeah. It's a win-win proposition. And so when we sort of add up where we want to spend the money, this comes up high on the list.
Dr. Christensen, it seems to me that what we do in this country, and particularly in the Medicare program here, is tremendously undervalue and underpay primary care. So fact check a little bit what the economists have just told us from a doctor's perspective and from somebody who's laid hands on patients. What's the scoop here? Mute. You're on mute.
On reimbursement for physicians?
Yeah, just generally.
I've been out of practice for quite a while, but it was always, family physicians are always on the low end of the fee reimbursement scale. And our role is so important because we are the health home for patients. We coordinate care. And so something needs to be done about that. But as I was listening to everybody else, I remember when Medicare Part D was passed, and we sat down with patients at home in the Virgin Islands to go over how to choose their Part D plan. People would come in with bags of medication.
Yeah.
And managing that medication and thinking about the cost of that medication had to be tremendous. And my research has been showing that even though a prescription drug may not increase in cost, the copays still increase. And so this is a very, very important issue. I can speak about people on end-stage renal disease. Their copays are generally in the around $10,000 a year, and a lot of that is the medication that they have to take, and they don't always. They're not able to work, first of all. So that $10,000 is very, very unaffordable for most of them. 80% of people on with end-stage renal disease are too sick to work. Many of them are unable to afford Medigap coverage. And so they're struggling to bear the cost. Now, Medicare does say that, does mandate for those over 65 that they have Medigap coverage, which will help. Some are on Medicaid, but not every state has Medicaid expansion, and making it not eligible for many people who should otherwise be covered by Medicaid. But one of the boards that I sit on is the American Kidney Fund, and we pay 75,000 patients premiums for Medigap, because Medigap is I wanted to just focus on that for a minute because it's so important. And while it's mandated for individuals over 65, it's left to the states to decide whether they're going to be mandated or not. And there are 20 states that don't mandate Medigap coverage. And so people are still left with a lot of out-of-pocket costs if they're not able to access a charitable premium program like ours at American Kidney Fund. And so the cost of medication continues to be a burden for them. And not only that, but they're not able to get on a transplant list. So
Yeah.
if we can just keep the patients, as a family physician, you're always focused on your patient. And if the healthcare system could just focus on patients, and it is very, very clear that if adherence to the medication and the physician care, maintenance care is adhered to, that people will be healthier and healthcare spending will eventually decrease. I'm glad to hear, I think Dr. Thorpe said that CMS is beginning to understand that. That's been a major battle with CBO during our discussions on ACA, getting them to understand that if you pay up front and lessen the cost for patients, that they will seek care, they will be healthier, and the cost will go down. And I'm glad to hear that there's more research that backs that up, because that's going to be a key to getting this kind of cap passed and enacted into law.
I'm really glad you brought that up. And it strikes me, just listening to the conversation here, the very idea that we have Medigap suggests that there's a problem, which is one of the things we're sort of trying to address here. But CMS has actually, very powerful tools, that were given to them by the ACA, and the most powerful perhaps is the Center for Innovation. And CMMI is really focused on a lot of these chronic diseases as a major target, because as we've discussed, is where all the spend is. The most recent, the REACH ACO program, which stemmed from the direct contracting program, which stemmed from the ACOs, really focuses on keeping people out of the hospital. Let's do everything we can. And in some cases, I think, as Dr. Christensen pointed out, maybe that's about keeping people on their meds. And in some cases, maybe it's about not getting them on the meds in the first place. So give those policymakers the tools to do to allow the providers to give the patients the tools to do the right method of care. So that focus on primary care, I agree, is really critical. But thinking, let's put CMS's hat on for a minute, and I'm going to ask Michael Ward to like maybe touch on this a little bit. What do we think CMS wants to do? I mean, clearly they've given some technical advice to Congress, but it's not necessarily CMS's place to go to Congress and say, hey, this is the way we want to change the drug benefit. Like if you were CMS and you were thinking the way these particularly the people at CMMI think, what kind of benefit design would you look at, Michael?
Yeah, I mean, certainly there's a few dynamics in which the parameters of the models that the Innovation Center puts forth. It has to lower cost and improve quality, and in lieu of, and if it improves quality at a minimum, it can be cost neutral, but increasing cost is kind of anti what the initial statute for the Innovation Center kind of laid out. And so those are kind of the two benchmarks. CMS recently released a strategy refresh for the Innovation Center, which included focus on health equity outcomes and other important factors that may not have been as front and center 10 years ago. So those have been really important. Now, I will say that in our recent discussions with the Innovation Center with Liz Fowler and with staff, they're similar to what PSCD is talking about here. They're very interested in expanding upon the success of the senior savings model, which is focused on insulin. They've seen the successes of that. And they're interested and open to ideas on kind of the next frontiers, the next condition areas to which to expand the program. I think that going into that, I think there was a lot of low-hanging fruit in the insulin space and the diabetes space in terms of kind of a more standardized product, and although there are some differences between insulin formulations and delivery. But I would say there were some low-hanging fruit. They're able to, get a number of contracts and agreements, rebate agreements in place with manufacturers. So I think, as we're thinking through the next steps in terms of actually implementing the next disease states, we'll have to kind of think through some of those tough questions as well. But number one, CMS is really interested in expanding the senior savings model, kind of regardless of what happens in Congress. I think that's going to be a priority. They kind of have hit the pause button, I would say, because they have been kind of waiting with bated breath, as all of us have, to see if some of the patient affordability provisions that are included in the reconciliation bill end up passing. So they're in a little bit of a holding pattern right now, but they are very interested in in kind of what are the other concepts that they could include in other programs that they're testing, including the value based insurance design program, which has been going on for a number of years. So I think CMS is open to ideas from the patient community, and it's it's certainly incumbent upon us. We've been doing it to Project Oak, but for patients writ large to go in and share kind of well fleshed out ideas with the agency.
Other thoughts, Michael Mandel? Mute. You're on mute.
I agree with Michael that people are sort of waiting to see what's happening with the Build Back Better bill, because so much of the what kind of comes next really depends on that. I think that we can sort of use this as an opening, okay, and part of the negotiations for trying to sort of extend it beyond insulin to other chronic care diseases. That this is that there may be an odd opening right now. In part, I have to keep coming back to the larger economic framework, okay, and today's really poor inflation numbers kind of dominate the politics of this, much more so than even the healthcare consequences. And I think that politicians and lawmakers may be open to a different way of looking at things right now.
Yeah, and it strikes me too that while all the conversation's been about reconciliation, there's a ton of bipartisan support for this concept. value-based care in general, Republicans, Democrats alike, sort of agreed to, kick it forward with MACRA and other policies, back 10 years ago. And generally speaking, they kind of come together. Another area where I get the sense people are coming together is social determinants. And Michael, you brought this up. I mean, these diseases disproportionately impact people in low-income communities. Maybe Dr. Christensen, you actually headlined our last briefing before the pandemic on this issue. Let's think about what are some of the policies we could be doing that help in that area with health equity.
Well, when we talk about the out-of-pocket cost for medication or other costs of other healthcare costs, the sicker you are, the more you pay. And
Ridiculous.
find that because of the social determinants, because of systemic racism that still exists in the healthcare system and other facets of life, people throughout their lifetime do not get the kind of care that they should be getting. They're not accessing care. And because they're low income, they're more likely to be rationing medication. They're less likely to have any kind of insurance. And if they're in Medicare, they're less likely to have Medigap coverage unless they can find some assistance in getting that. So we come to Medicare sicker, requiring more medication, and therefore having the sicker you are, especially if you don't have a Medigap coverage or other insurance, your out of pocket is much higher than someone else's. And so what we need to do is to address the healthcare, the inequities in healthcare and the social determinants that fuel those inequities, and the discrimination, racial and ethnic discrimination in the system, to be able to bring people to Medicare healthier. And it's not happening enough, but I really appreciate that this administration and CMS are really looking at equity issues and how every agency can play a role in addressing the inequities, especially in the social determinants that other agencies have control over, so that people of African Americans, Hispanic Americans, Native Americans, all people of color, the poor, those in rural communities can get to the age of Medicare in a healthier state, and that will reduce a lot of the burden of healthcare spending on the federal government. It will improve the quality of life for patients, and just a lot of good outcomes all around.
So Jay, let me just build on that. Because I think, again, this is another area where CMS has done some positive things. Again, it's running through the Medicare Advantage program. But if you look at what CMS is allowing the MA plans to do in terms of flexibility, they're now allowing them to use their rebate dollars to cover non-medical services, things like housing, transportation, social services, and so on. So I think that there's some good directions that we're moving, both in terms of value-based insurance design and integrating non-medical healthcare benefits into the management of patients, because we know, I mean, sort of public health 101, if you look at the major determinants of the health of a population, medical care is critically important, but the main determinant are really these social determinants. And until we figure out a way to integrate these social determinants into the management of patients that have 5, 6, 7 chronic conditions, things as simple as going into the home and do fall detection issues, a huge issue for seniors in terms of preventing falls. There's a variety of things like that that we're increasingly going into. And I think, again, in the policy discussion on seniors has got to focus on these issues that are really going to affect their health outcomes. So it's the out-of-pocket piece, primary care, integrating non-medical care treatments into a treatment plan, good care coordination. These are all things that traditional fee-for-service Medicare doesn't do. I mean, they try to do it through ACOs and so on, but the dilemma that we've always had with the fee-for-service component is that since Medicare doesn't really pay for care coordination and they don't include social determinants as part of the Medicare benefit package, when CMMI or CMS sets up the targets in terms of per capita spending for ACOs, that's not in those dollars aren't in the baseline. They don't have the dollars in their baseline spending to develop sophisticated care coordination and prevention programs. They obviously don't have the capacity to really include in those base dollars housing, transportation, fall prevention, and so on. So, I mean, I think that there's some really positive directions that are going on for half of the Medicare population that we have to figure out a way. How do we transmit and move those things that are happening for half the Medicare population into the traditional fee-for-service Medicare program?
Yeah, for sure. It strikes me too that another one of these areas is telehealth. The data from the pandemic showed that Hispanics, people of color, low-income communities had the largest increase in utilization in telehealth, and a lot of these incentives are set to expire at the end of the year. Any thoughts on that and how that can play a role?
Can we actually just go back to something the Congresswoman said about the sickest patients pay the most? Okay, and that's kind of a consequence of the way that the Part D benefit package was set up, the copay system, and that's really kind of what we're sort of talking about here. We're kind of talking about going back to fundamentals and making sure that we're not in a world in which the sickest patients pay high copays and kind of stacked on top of copays, and it may seem like that we're giving them an extra benefit, but really we're not. We're sort of making sure that they're getting what they deserve.
Yeah, I mean, again, it's not Michael, it's not an extra benefit. I agree with you. I mean, it's just common sense in terms of taking a look at clinically, what's the best approach for managing a really sick population of patients. And it's by eliminating or capping what they have to pay out of pocket for a wide variety of chronic condition medications. I think to Jay's point, telehealth is critically important. And we've seen tremendous data out of Israel on this in terms of what they have done in terms of telehealth and remote patient monitoring, where being overrun by COVID patients, they had to release some fairly sick patients earlier than the physicians were comfortable with, cardiovascular patients among others. But they developed some incredibly innovative technologies on remote patient monitoring that allowed the physicians to keep track of the patients at home and to make sure that they could intervene early through some very sophisticated monitoring techniques and devices that they have. So this transition of where people get healthcare is on the move. It increasingly is going to be at home. And so the most efficient way to do home care is really through telemedicine and through really sophisticated remote patient monitoring techniques, which exist. There are devices out there right now that in one single device allows you to monitor 13 vitals in a single device that has proven scientific metrics that show that they are accurate as anything that you see in a hospital. And it allows you to develop early warning signals for patients to intervene. So again, I think this is part of the broader discussion about what can we do to reduce Medicare spending, reduce spending overall. I think telehealth has the potential to do that. And I think, if we sort of cut back on it, I think it's going to be very upsetting to a whole range of patients who've gotten really used to getting their health care at home.
Yeah, the only good thing that came out of this pandemic is that both providers were more willing, well, they had to adopt telemedicine, telehealth, and patients were more exposed to it, and they like it, and it's worked well, and we just can't go backwards now on that. And there are a lot of advocacy groups out there that are really pushing that and hoping that we can utilize even the infrastructure bill to ensure that broadband is widely available to communities that have not had it, and
Yes.
expand on this avenue for patient care.
Yeah, that's a great point. You can't use telehealth if you don't have the device that you need to use it, but there are ways to facilitate that. I do want to. We're about 10 minutes out. I want to shift some questions from the audience, and one of them hit on some of the things we were talking about around social determinants with regard to the Z codes for reimbursement for some of these things. And Ken, you talked about it a little bit. The question from the audience is there's lots of talk about making these things reimbursable. Do you folks have any ideas about that, or any understanding of what direction CMS is moving in that might be helpful in this area?
I don't know where that is right now. Maybe Michael, or either Michael might be able to.
Yeah, Michael Ward, do you have any Z codes? It was a pretty in the weeds question. I want to make sure it got answered. These are the codes for reimbursing the things Ken is talking about, like getting to the pharmacy so you can get your meds, or, getting to your appointments with transportation or housing or other things.
Yeah, I think that the example that was mentioned in Medicare Advantage shows that taking care of all of the patient and their environment has tremendous benefit to the patient and to healthcare spending.
Yeah, I'll just say writ large. I mean, there have been other flexibilities around billing that were extended during the public health emergency, including around, for example, in long-term care settings that they allowed clinicians to bill for vaccination for COVID, flu, and pneumonia. Before that flexibility, they were just billing that as part of the package, kind of the Part A billing. And a lot of providers are actually losing money on that. And so it kind of discouraged what should have been a basic practice, right? Like if you're in a congregate setting, having a flu vaccine clinic or a COVID vaccine clinic, in place where a lot of people have mobility issues and other challenges that wouldn't allow them to leave the facility, just makes sense from a clinical perspective. And so I think to the extent that we're able to build upon that, to allow the types of flexibilities that allow for a holistic view instead of just looking at medical care, kind of having a whole, let's consider the other things. Does a diabetic have a working refrigerator that allows them to store their insulin? Because if they can't store their insulin, then they're going to end back up in the hospital. But a lot of those things are kind of outside of the normal realm of what a clinician, in the ER would think of, or would kind of be down their list of things to ask. And so I think to the extent that CMS can align incentives by allowing these really important services to be reimbursable is a step that's necessary.
I completely agree with that. And again, to the point raised earlier, CMS did this with telehealth. There's been a dramatic change in reimbursement, place of treatment, the range of codes that you can bill for telehealth services that, as Dr. Christensen talked about, that came out of COVID, really by necessity and also by, I think, consumer choice. And again, I think it's one of the limits of a CPT-driven fee-for-service system that some of the value-based designs, whether it's MA or whether it's things like bundled payments, for example, and anything that's sort of migrating away from sort of encounter-based, CPT-based billing, I think is going to be positive here, because we've got to have somehow the flexibility to allow providers to put together a set of services that are best situated and best geared to really help that patient stay healthy. And it's not just sort of the existing CPT codes, it's going to include things that I've been talking about before, housing, transportation, fall prevention, things that are outside of the traditional CPT medical world. But we've got to find a way in the fee-for-service Medicare world to think this through in a little bit more, I think, aggressive way to recognize that the management of these patients is not just, a patient encounter in the physician's office. It's really much broader than that. And we need to come up with approaches that really help patients and physicians do a better job of keeping those patients healthy.
Yeah, it strikes me that a lot of the move to value-based care is really about, paying for that value. And in most cases, that the high value is that relationship between the doctor and the patient, where they can figure these things out. And some of these payment models have the flexibility to do those sorts of things, upfronting without cost share, the cost of primary care and other things that REACH and other programs are able to do. But Michael, you mentioned the idea of smoothing, and we did get a question from the audience to sort of expand on that. In these proposals that are in front of us, how would the smoothing proposal work to help decrease the burden of out-of-pocket costs?
Sure. Well, I mean, smoothing is really kind of it's a value add because, we've talked a little bit about a cap, but a cap by itself, Dr. Thorpe kind of mentioned it. If you have a $2,000 cap, I think, that by itself still presents a lot of challenges. If someone goes in and they have 10 prescriptions and they're still at the pharmacy counter in January when they're in that deductible phase where they're responsible for the full freight of their costs, especially, they could be looking at $1,000 out of pocket right off the bat. And so that can still be a deterrent to people getting care. So if we do have a cap in place, having a no interest payment option where you can spread, what would eventually be up to $2,000, spread that over a course of a year where it's kind of in smaller bites, where people are able to kind of afford that, especially if they have, if they're living on Social Security and they have, a set amount of money that they're trying to budget for each month, and they can't afford that $1,000 at one time. I think that's really important addition to thinking about, in addition to a cap. I mean, a flat copay I think is certainly the way to go and should be the way, and for many conditions is ideal. But in lieu of that, I think a cap with the ability for people to be able to spread out their costs with zero interest over time is helpful as well.
Well, with about 2 minutes left, I'd like to just go around quickly and see if our panelists have any parting thoughts. Dr. Mandel, let's start with you.
I'm just going to come back and pound on the same point that I've been making, which is at a time of rampant inflation, one of the biggest anti-inflation moves that the government can make is extending capped copays to chronic disease drugs. And that's something that could be done right now in a way that actually benefits real people in Part D.
Dr. Christensen, parting thoughts.
I'll second that, but I just wanted to mention something in regard to the second question that came up. We had legislation that still exists that has not been passed to create health empowerment zones. And Maryland did adopt our concept, and it has made improvements where they have been established. So, and the concept is that not only the medical issues are addressed in that zone, but that they would have primary access to programs, whether it's housing, whether it's EPA, whether it's in small business, to address the social determinants as well as the healthcare needs of the community. And that was one way to address it. I'd also just want to mention the PCORI, the Patient-Centered Outcome Research Institute, also could probably bring some important information to this discussion.
Indeed, that group has furnished a lot of the data that's gone behind some of the thoughts in this conversation today. Michael Ward, your parting thoughts.
Yeah, I think I mean, there's so much agreement that something needs to be done around Part D affordability. And I think that the time is ripe. It's just time for, I would encourage certainly our policymakers to kind of unite behind the ideas in which there is widespread support and to do something meaningful for patients, because they can't wait for for kind of partisan divisions to stop them from being able to access the medicines they need.
And our chairman, Ken Thorpe, you'll get the last word.
Well, thanks. And thanks again for everybody for sticking with us through this discussion. I think if we're going to do broad reforms of whether it's prescription drugs or other components of our healthcare system, first, it shouldn't be just based on scores and budget driven. If we're going to make changes, it's got to focus on how can we improve health outcomes, how can we improve the quality of care for Medicare beneficiaries in a way that's thoughtful. And one way to start this is by simply recognizing the link between out-of-pocket costs, adherence, health outcomes, mortality rates, and so on. That's a terrific start. I think we can expand the discussion into other areas that says we know that managing these very complicated patients will require things that are outside of the traditional medical care system, and we need to find innovative ways of integrating that into the treatment plans. But I think to have a discussion about whether it's hospital costs, physician costs, clinic costs, we know that everything in the United States healthcare system is 2 times higher than Europe. Drugs, hospitals, outpatient clinics, surgical procedures, and so on. So I think if we want to have a real discussion about reforming our system, we need to find and focus on what's driving it. And one of the big differences that's driving it is differences in disease prevalence in this country, and differences in the fact that we don't do as good a job as possible in managing these patients to keep them healthy. So I think any policy proposal moving forward has got to focus on the real end goal here, which is keeping these patients healthy, keeping them out of the hospital, keeping them out of the emergency room. And the great way to start right now is by capping or eliminating what patients with multiple chronic diseases have to pay out of pocket.
Well, that'll be the last word. What a great discussion. Thank you to our panelists for joining us today. Thanks to the participants. We really appreciate your time today and look forward to continuing this conversation in the future.
Thank you.